Good afternoon. I'd like to thank Dr. Galvo Nieto and the program committee for the opportunity to present on single anastomosis bariatric surgery. I have no disclosures relevant to today's talk. I would like to begin by setting the landscape of two of the most effective and prototypical bariatric operations, the classic gastric bypass and the classic biliopancreatic diversion with duodenal switch. The classic bypass was originally described with a loop GJ. This was ultimately reconfigured to a Roux-en-Y to address several problems with the original operation, namely bile reflux, marginal ulceration, and a subsequent increased risk of gastric cancer. Though successful, this change added additional time, complexity, as well as mesenteric defects and interrupted normal peristaltic signaling. In 1997, Dr. Rutledge proposed return to a loop configuration with the mini gastric bypass, ultimately which came to be known as the one anastomosis gastric bypass. A similar modification of the duodenal switch was proposed by Sanchez-Pernot in 2007 as the SADI-S with a progressive metamorphosis in the common channel length, initially to 200 centimeters, and then further lengthening to 250 centimeters. Later, in 2015, this evolved into the SIPS operation in the US with a common channel length of 300 centimeters. For the purposes of this talk, both SIPS and SADI will be referred to as a single anastomosis duodenal switch, or SADS procedure. Both of these single anastomosis operations go by many names, several in English, one in Spanish, but for the purposes of this talk, we will be using the one anastomosis gastric bypass terminology. SADS will be the primary terminology used to refer to all variants of the modified duodenal switch, including SIPS and SADI and their related procedures. The prototypical operations from which these all hail, the Roux-en-Y gastric bypass and duodenal switch, demonstrated significant improvements in weight, diabetes remission, as well as improvements in metabolic syndrome. Mingrone et al. Demonstrated all of these facts, with similar evidence being reflected in the 5-year results of the Stampede trial published earlier this year, with the exception that this included Roux-en-Y gastric bypass and sleeve gastrectomy as the bariatric operations. What was shown in this study was that the Roux-en-Y gastric bypass actually had significantly improved metabolic effects relative to sleeve gastrectomy. Despite that, the worldwide frequency of sleeve gastrectomy is increasing annually, now comprising 60% of all operations, with declines in the rate of gastric bypass to 30% worldwide and 17% domestically, with duodenal switch comprising less than 1% of all operations performed. The one anastomosis gastric bypass differs significantly in that the pouch configuration is longer and narrower. One of the reasons for this change is to reduce the degree of bile reflux esophagitis. And there is a 200 centimeter afferent limb prior to the loop GJ anastomosis. Italian data seems to demonstrate that the rate of complications for a one anastomosis gastric bypass is less than that of either a traditional gastric bypass or of a sleeve gastrectomy, despite its lower incidence of being performed. The geographic distribution of this operation seems to be clustered in Asia, Europe, and the Middle East, with very little penetrance into other geographies. IFSO 2019 report compares Roux-en-Y gastric bypass to one anastomosis gastric bypass and sleeve gastrectomy in terms of comorbidities improvement. 3 representative comorbidities are shown here: sleep apnea, type 2 diabetes, and hypertension, all of which demonstrate improvements more significant in the one anastomosis gastric bypass subset compared to either of the other noted operations. With regards to operative and perioperative events, there's a decreased operative time of almost an hour in a one anastomosis gastric bypass, less early complications, and clinical outcomes at 2 years that are nearly equivalent between both groups, with a clinically insignificant difference shown in hemoglobin levels. Though weight loss and diabetes resolution are shown to be the same, certain other data sets seem to favor one anastomosis gastric bypass in terms of diabetes resolution. There are several positives that come from this, mainly as a result of a decreased number of anastomoses with very similar clinical outcomes. Potential negatives include bile reflux esophagitis and risks of cancer and malnutrition. Long-term data is limited and some of these questions remain unanswered. Other complications resemble that of a long limb gastric bypass with the exception of GERD and bile reflux. With regard to duodenal switch and its varieties, there's several technical differences in terms of sleeve diameter, but main differences are pertaining to the common channel length, with the SADI being 250 and the SIPS being 300. They're going to be referred to categorically going forward, and some of the representative data mentioned in aggregate. The positives are that there's a negligible rate of marginal ulceration, as this is a duodenal anastomosis, highly effective in terms of weight loss and comorbidity resolution. However, the duodenal switch does include a significantly higher operative time due to technical difficulty and can have increased rate of complications and long-term diarrhea and malnutrition. The modification to one of the SADS procedures does offer significant improvement in terms of frequency of diarrhea and malnutrition in patients. Other benefits are the post-pyloric nature of all of the duodenal switches is less dumping and hypoglycemia relative to the gastric bypass cousins. A longer 3-meter common channel causes less diarrhea and less malnutrition. Decreased number of anastomoses decreases complexity, operative time, eliminates a mesenteric defect as well. Sanchez-Pernault presented data from the first 300 cases over 10 years without a single internal hernia being noted in those patients. Data with regards to overall weight loss shows that of sleeve gastrectomy, gastric bypass, and SADS procedures, that the SADS has the highest overall excess weight loss percentage of almost 89% at 2 years. Similarly, improvements in hyperglycemia as measured by hemoglobin A1C is most notable in this same patient cohort here at an 18-month time point, which is more than 50% higher number of respondents than a Roux-en-Y gastric bypass. To summarize the operations discussed so far, our one anastomosis gastric bypass has very similar overall results and perhaps higher diabetes resolution relative to the traditional Roux-en-Y gastric bypass. Single anastomosis duodenal switch is comparable weight loss to that of a traditional duodenal switch, and perhaps even higher rates of diabetes resolution. Both the one anastomosis gastric bypass and the single anastomosis duodenal switch offer comparable results to their two anastomosis relatives. The position of their anastomoses relative to the pylorus differs and can have impact on the rates of dumping and marginal ulcer risk between these two categories of operations. The elimination of one anastomosis decreases operative time and complexity for construction of these operations, and these both offer promising avenues for treatment, both as primary bariatric operations or as revisional bariatric operations. Both of these are currently recognized by IFSO as non-investigational in nature, and ASMBS just earlier this year has endorsed the SADS procedure as well. Thank you for your time.